Assalamu alaikum. Good afternoon, everybody. Thank you, Dr. Abdallah and the organizing committee for inviting me for this prestigious conference. I know we are tight in time, so we have to know about that heart failure with reserved ejection fraction, one of the commonest type of heart failure now. And I think you see these slides from Dr. Abdallah Shahab, so my task now is very easy. But the problem is that the prevalence of heart failure with reserved ejection fraction increased by 1% annually in comparison to the heart failure with reduced ejection fraction. And as we can see, the prevalence increased with age and higher in female than in male. One of the most complicated things about the heart failure with reserved ejection fraction is the comorbidity that is associated with its pathophysiology, like anemia, obesity, hypertension, coronary artery disease, HFpEF. Now we are going to focus about the obesity. There is unmet need for therapies that reduce the cardiovascular event and support weight management. Why? Because 988 million people estimated to live with obesity at the 2020. This number can increase to 1,556,556 at 2030. And if you look to the prevalence of obesity in the Gulf region, this is, you can find in the EA, the percentage of body mass index more than 25 is 68%, and body mass index more than 30 is about 32%. We know obesity is considered as a risk factor for cardiovascular disease. Why? Because it's associated with increased blood pressure, increased blood glucose, increased insulin resistance, increased blood level, and one of the most important mechanisms is inflammation. Inflammation is one of the cornerstone mechanisms in the pathophysiology of the obesity and the occurrence of cardiovascular disease, especially heart failure with reserved ejection fraction. So what are the mechanisms through which obesity may contribute to the development of heart failure with reserved ejection fraction? Obese patients are associated with decreased chest wall compliance, increased leptin level, renal aldosterone activation, BNP level. This will lead to increase the plasma volume, increased sodium level, increased inflammation. Again, it's very important. And at the end, we can reach to left ventricular stiffness, feeling pressure with heart failure with reserved ejection fraction. And as we can see, the obesity with the incidence of heart failure with reserved ejection fraction increase with the obesity. This is the link between the obesity and the cardiovascular disease. Obesity, reduced lipid turnover, inflammation, systemic inflammation in presence of interleukin-6 and other inflammatory marker. This will lead to decreased insulin secretion and decreased glucose intake, increased insulin resistance, type 2 diabetes, decreased cholesterol metabolism, increased glucose production, increased insulin resistance, plus increased endothelial permeability and increased plaque development and atherosclerosis. This will lead to cardiovascular disease. And as we can see, the weight loss may improve the quality of life and exercise capacity in obesity phenotype of heart failure with reserved ejection fraction. And as we see, weight loss may improve obesity-related comorbidities about 5 to 10% of weight loss. This will associate with reduction in cardiovascular mortality. So now let us go to pharmacotherapy, and one of the most important things that newly introduced in the field of obesity and heart failure with reserved ejection fraction is the cardiometabolic benefit of novel incretin anti-obesity medication. And of course, one of the most important mechanisms is GLP-1 receptor agonist. Why? Because it's important. Because we can see that they have a proven cardiovascular benefit from leader trial. We can use liraglutide and Rewind trial liraglutide, and even sustain 6 with semaglutide subcutaneous all associated by greater reduction of the cardiovascular event and MACE point. So, what about heart failure with reserved ejection fraction? It's a new frontier for GLP-1 receptor agonists. Why? Because the cardiometabolic heart failure with reserved ejection fraction, there is no prior trial therapies in the heart failure population. And as we mentioned that more than 80% of patients with heart failure with reserved ejection fraction related to obesity. One of the important trials that recently published, and I think this trial has gone a strong impact on the guideline, is the STEP heart failures with reserved ejection fraction. This is a trial design. It's about 529 patients randomized to semaglutide 2.4 milligram once weekly plus the standard of care versus placebo once weekly plus the standard of care, and the follow-up to 5 weeks. And let us see the effect on the primary endpoint. This is the objective of the trial. It is randomized, double-blind, placebo-controlled, multi-center trial. The goal is to evaluate the effect of semaglutide versus placebo in patients with obesity, of heart failure with reserved ejection fraction, with or without type 2 diabetes. This is very important as regards the physical function, body weight, inflammation, and symptom. and this is the result. There is significant increase in mean 6-meter wall exercise with semaglutide 2.4 milligram versus placebo. Again, there is significant improvement in the Kansas cardiomyopathy questionnaire with semaglutide 2.4 milligram versus placebo at week 52. Moreover, there is significant decrease in the mean body weight with semaglutide 2.4 versus placebo at week 52. So it was associated with a very and marvelous result for especially of this type of patient, obesity phenotype with preserved ejection fraction. And as we can see here, semaglutide reduced clinical outcome in heart failure with preserved ejection fraction. This is, by the way, pooled analysis of different trial, select trial, flow trial, step heart failure, preserved ejection fraction with or without diabetes. This is about 3,700 patients. And as we can see, time to first worsening heart failure event or cardiovascular death associated by 31% risk reduction risk. So it is an amazing result for when we're using the semaglutide for this kind of patient. Still, we have a gap in obesity care, gap related to the patient and the gap to the healthcare provider. Most of the patients, still 82% consider weight loss to be completely their own responsibility. Only 55% have received a formal diagnosis from their healthcare provider. Of those receiving diagnosis, only 24% have follow-up. And the doctor, healthcare provider, they don't have time for more important matter to discuss with the patient, and the healthcare provider set unrealistic weight loss target with their patient. If we look to the guideline, this is the 2024 ACC guideline for management of chronic coronary syndrome, and as we can see, GLP-1 receptor agonists with the proven cardiovascular benefit are recommended in patients with type 2 diabetes, chronic coronary syndrome, to reduce the cardiovascular event independent of the baseline of hemoglobin A1C. It is class 1A. Even patient without type 2 diabetes is class 2AB using GLP-1 receptor agonist. Again, this is the clinical guideline for cardiovascular prevention, recommended weight control, American College of Cardiology, American Heart Association. They recommended that for weight management in people with obesity who don't have type 2 diabetes, the guideline states that lifestyle modification remains a cornerstone for obesity management. However, if sufficient weight less to be or cannot be achieved, the initiation of anti-obesity medication is reasonable addition. In CCS patient with a type 2 diabetes, GLP-1 receptor agonist, semaglutide by name, should be considered in the overweight if body mass index more than 27%, in patient without diabetes to reduce the cardiovascular mortality. So the conclusion now for the semaglutide consistently improve heart failure related symptom, physical limitation and exercise function, and reduce body weight and inflammation and NT-proNB as level regardless of the Kansas cardiomyopathy questionnaire. Semaglutide provide large independent on all key summary score and individual domain Kansas cardiomyopathy square. Fewer semaglutide treated patients experience a little bit deterioration or a little side effect. Collectively, the result of the study provides that additional support for semaglutide as a valuable treatment option patient with obesity and the phenotype of heart failure with preserved ejection fraction. So in summary, heart failure with preserved ejection fraction is a disorder where the heart fails to keep up with the circulatory demand of the body or does so at the expense of raised left ventricular filling pressure. Obesity induces hemodynamic and biohumoral changes leading to functional and structural cardiac remodeling, which ultimately result in heart failure, preserved ejection fraction development. Treatment approach target heart failure, preserved ejection fraction symptom, risk factor, comorbidity, and the cardiomyopathy. Significant weight loss result in increase in exercise tolerance, improve MRI and echocardiographic measurement of diastolic heart function. Of course, with the use of semaglutide, we can get all these benefits. At the end, thank you so much for your attention.